Good morning, everyone. Thank you all for having me here. I'm excited to share with you one of my favorite topics, the management of ocular surface squamous neoplasia or OSSN. I have no financial disclosures. So we'll be discussing a case of a 65-year-old gentleman who presented with a lesion involving around 90 degrees of the limbus. The question was, do we perform an excision or should we try something different? So we elected to treat the patient medically using topical interferon alpha 2b dosed at 1 million international units 4 times a week for 3 months, and the results have beautiful resolution. So what is OSSN? OSSN is an umbrella term encompassing conjunctival intraepithelial neoplasia, squamous cell carcinoma of the conjunctiva. The lesion can appear like gelatinous. It can be papillomatous, opalescent, and leukoplakic. The risk factors include UV light exposure, HPV, and HIV. The traditional management is surgery, which is gold standard. So you can see the pre-op and the post-op picture, which show the key benefits are quick resolution and diagnostic, as the excised tissue is sent for the biopsy, and therapeutic in patient who is non-compliant. But the downside is that microscopic residual disease may cause recurrence, and extensive excision can lead to limbal stem cell deficiency. So here, the steps of no-touch technique in surgical wide excision are there. So we take a 4 mm wide margin around the tissue. Orientation of the on the filter paper outlined with the pencil, not with the ink, because alcohol is there. It dissolves the ink. Alcohol epitheliectomy in case the cornea shows involvement. Sclerectomy in case the sclera shows involvement or the lesion is attached to the sclera. Cryotherapy using a double freeze thaw, and amniotic membrane for surface reconstruction. But even with careful technique, we can't always see the full tumor extent, especially when it spreads microscopically. So why consider medical therapy? So medical therapy, it treats entire ocular surface, multifocal tumor with indistinct margins. It addresses microscopic and subclinical disease, especially effective in recurrent diseases, in HIV patients with large tumor or bilateral involvements, and chemoreduction in large invasive lesions. So the drugs which can be used are mitomycin, 5-fluorouracil, and interferon alpha 2b. So we'll be discussing these drugs. Mitomycin C I use in a dose of 0.04 4 times daily for 4 weeks, followed by 2 weeks off. Repeated in cycles as needed. It is painful and causes corneal epitheliopathy. So I call it as a devil drop. So this is a case which was treated with mitomycin C. You can see in the first picture OSSN with diffuse corneal involvement with papillary conjunctival nodular component in the inferior limbus. And in figure B, you can see appearance following 1 cycle of MMC, 0.04% eye drop. And in C, you can see following 2 cycles of MMC and complete resolution after 3 cycles, showing minimal corneal epithelial scarring also. With 5-fluorouracil, it is dosed 4 times daily for 1 week, followed by 3 weeks off. It is less expensive, more stable than MMC, also painful but less than MMC, so I call it as assistant devil drop. So this is the picture showing OSSN after 2 cycles of 5-FU, and you can see a good resolution. So the third and my preferred therapy is interferon alpha 2b. It is a low molecular weight glycoprotein with antiviral and anti-neoplastic properties. It is given in a dose of 1 million international units 4 times a day daily until tumor resolution plus 1 month after the resolution. It is gentle, kind, no toxicity, requires daily use, refrigeration. I call it as angel drop, and if I can trust the patient with will be compliant, this is my first line of therapy. Subconjunctival injections of interferon when compliance is a concern. So we get multiple dose vials. I inject once every week, and 6 injections per vial can be obtained, and patient gets flu-like symptoms which are treated by paracetamol or sub injections, antipyretics. So my decision tree goes like a good compliance patient, then topical interferon, poor compliance, then interferon injections, and failed interferon, then MMC or 5-FU or surgery. So what could make medical therapy better? So to improve medical therapy, we should diagnose OSSN without biopsy and know when the tumor is truly gone. So spectral domain OCT, which is a magic genie which comes handy, And OCT features OSSN with a thickened hyperreflective epithelium, abrupt transition from the normal to abnormal tissue. You can always compare with the scars and pannus, which show thin and non-reflective epithelium on OCT. It allows pre-treatment diagnosis, monitoring during the therapy, and post-treatment confirmation of resolution as well. So to summarize, a surgery is effective but carries risk of recurrence and stem cell loss. MMC, FFU, 5FU, and interferon are excellent non-surgical options. Ultra high resolution OCT helps in diagnosis and tracking treatment success. Topical interferon remains my first line of treatment when compliance is not an issue. Thank you.
Thank you, Dr. Nitish. Any questions? Anybody else?
Because the injection which we get, it is not approved by FDA, so we have to make it in the OPD. So we make an injection, we get an injection of interferon, which is 3 million international units. So we reconstitute it and give the patient in a eye drop, and it has to be reconstituted every 15 days. So that's why patient compliance for 15 days is very important. Longer term of follow.
Availability is also an issue. Sometimes we don't get interference.
Yeah, we do.
Availability is an issue. In TAS used to make, they have already stopped. Reliferon is the only